What I want to do today is take you away from maybe what you've been thinking about for the last day and a half and get you to put on your futurist glasses and think about what will this exhibit hall look like 20 years from now. If I think back 20 years before, the exhibit hall looked very different. There were many more bracket and wire companies, plier companies. There were computers, but they were primarily for practice management. And if you think about that transition over 20 years and then extrapolate 20 years from now, based on how fast things are changing, I think we'll see that there's going to be some great differences. So again, Myron kind of outlined my background. I want to just emphasize that I have no financial interest, arrangement, or affiliation that's related to this presentation. I also have to give due to Dr. Prophet, who is my mentor. And this is a photo from when we were working together on the 6th edition of Contemporary Orthodontics. And Henry Fields, David Sarver, and I are just completing the next edition, and it's been quite a difference working without Prof on the team. I always realized what a guiding light he was, but when you operate in his absence, it becomes even more clear. So he taught me so much about how to think about things, and one of the things that really resonated with me is he would often say to people that were promoting certain things that you're entitled to your own opinions, but you're not entitled to your own facts, right? And I think that's something that many of us sort of hold dear. So if I think about giving the Salzmann lecture, I think about Salzmann himself being very interested in imaging. And this is from a 1964 publication that he was talking about the limitations of cephalometrics. And one of the things he emphasized was the inability to visualize asymmetries. And he, by this time, even though Bolton and Broadbent started out with three-dimensional imaging by taking a simultaneous PA and lateral radiograph, by this time people had pretty much settled into taking the lateral ceph and working from there. But he explicitly called out that limitation in this paper, and that's why I think three-dimensional imaging has become so important in what we do today and what we do in the future, and again, thinking 20 years from now, how much more important that will be. The last paragraph of this paper is on the screen. And the thing that, again, sort of resonates with what Prof told me was that orthodontics needs more science and maybe a little less art and artfulness. So my thought today is to try to help you look into the future, but sprinkle it with a little bit of the beginning science that we've are trying to contribute to this evolution of imaging and visualization. So what we're going to try to do today is help you understand a little bit more about MRI, if you're not familiar with that, and think about how this may be able to lead us to having what we're calling DD MRI, or dental dedicated MRI, and how that may contribute to our orthodontic practices. We also want to discuss a little bit about visualization and how these 3D data sets create a lot of information that we need to process. And then, again, our focus is really to think about and create a vision for the future where we put all this information together in a way that actually benefits our patients. So when I think about 3D imaging, my earliest foray into that is that paper that's listed in the bottom right of the screen. And this was a paper that I was involved in at the Mayo Clinic. And remember a minute ago I talked about that Bolton cephalometer that did 3 dimensions by taking a simultaneous, so there was no patient movement, lateral and PA ceph. So if you could identify the same point on both images, you could create a 3-dimensional coordinate, right? So this paper was done using some of the surgical fixation screws, sort of as those landmarks that we could see in both images. And so that got me interested in thinking about things, including that 3rd dimension. Then when I moved to the University of Minnesota in 2004, there was a local orthodontist, John Barton, that had this imaging center. And for years he was an orthodontist himself, trained at St. Louis University, I believe. But he provided imaging services for 4 or 5 orthodontists by taking cephs and PAs and pans and photographs for various offices. Well, he was really excited because he had gotten one of the first new-tone CBCT machines in the country. And so he had me out to his office, and of course he puts me in the machine, and I come home with this 3-dimensional image of my head, which is a little scary to think of, but it really, I was just enthralled. I said, wow, this is really something. We have to think about doing this, and how can we fit this into our research and training program? So that's what really lit my fire to think about moving in the direction of 3-dimensional imaging more robustly. So the reason that this has been possible for us at the University of Minnesota is because some really generous donors have helped us out. And John Barton, that I mentioned, was one of the first that contributed to our imaging and 3-dimensional group. But we have this 3D digital lab now that you guys down in the front here are all familiar with. But it was a very generous benefactor that gave the money to do this. And so when we first put it together, we provided him with some images of all the things we were doing. We do 3D printing and scanning and force measurement and trimming. And he was so enthralled by that, he doubled his donation. He said, this is great, do more. So these are the dollars that we're able to invest in doing some of these projects. So in 2004, when I got that first CBCT, I started to think a little bit more about where are we going. And this is a title slide from a presentation that I gave in Australia in 2006. And the focus was we were undergoing this transformation in 2 different ways at the same time. One was from analog to digital, because a lot of us were still imaging with film in those days. And at the same time, we had this transition from 2D to 3D. So this is now almost 20 years ago. And some of the predictions I made in that talk came true, and others sort of fizzled out. And I'm sure the same will happen for the visioning we do today. But I think it's a really important thing to think about where we came from and how we got to where we are today as, again, we visualize the future. To help people think about seeing things in more than 2 dimensions, I actually brought along these cheap little 3D glasses that I put on every seat in the auditorium, and at the end of the presentation we put up some 3D images of lots of things, including teeth, so people would just sense that there's more to visualization than just looking at a flat screen. So as we progressed, in 2008, we started imaging at the university in 3D for all comprehensive orthodontic patients. And at the time, Vince Kokich Sr. was the editor of the AJODO, and we would sit together next to each other at AAO board meetings. And sometimes board was B-O-A-R-D, which was really enthralling. Sometimes it was B-O-R-E-D, and Vince and I would be talking kind of sidebar. And I was telling Vince how I thought this was so amazing visualization of, impacted teeth and just skeletal relationships was so amazing. And he says, well, if it's so good, I want you to write this point for the AJO. And of course, those of you that think back to that time, Vince had this point counterpoint thing that he liked to do. And so I wrote this paper about why I thought this was the imaging of choice and what made it better. And of course, Vince asked Demetrios to write the counterpoint. And he did it very thoroughly and thoughtfully, as we know he would. And when you look at what he was critical of, he wasn't critical about any of the 3D imaging. What he was critical about was the radiation dose, right? And so his conclusion was, except for certain patients, replacing the conventional Ceph and Pan with large field of view CBT is simply overkill, potentially leading to a public health program, okay? So his criticism, again, wasn't of 3D imaging, it was the way we acquired it. Since that time, there's been a lot of evolution of CBCT, and the dosages have dropped even further, and that sort of hindered the development of using MRI because, again, the dosage were almost getting down into the range of a conventional Ceph Pan. But he got me thinking so much that 12 years ago in Hawaii, I gave a presentation at the AAO annual session about MRI, and I said, does it have a place? And one of the things that, or several of the things that I talked about was that it has advantage because it's an alternative imaging technique in 3D. The biggest thing is it doesn't require ionizing radiation to acquire the images. It allows visualization of soft tissue. We become so hard tissue oriented because that's what we visualize, right? But if we think about what David Sarver and others have been emphasizing for the last couple decades, it's really soft tissue that's meaningful. And in reality, we need both, right? We need to know where the hard tissue structures are, and we need to know the soft tissue. But MRI has considerable ability to image soft tissues. And then the other thing that happened right in that time was some new acquisition parameters that allowed better hard tissue imaging and reduced scan time. So this is an article from our Center for Magnetic Resonance and Research at the University of Minnesota. And Mike Garwood, the senior author on this paper, still works with us in the dedicated dental MRI space. And they developed this different way of acquiring MRI images that I'll show you a little more detail in a minute that helps to revolutionize how things are done. So in order to think about MRI, it's important that we know a little bit about how it works. And I am by no means an expert, and many of you may be more schooled in the basics of MRI, but I want to give you just a little information so we're all kind of talking about the same thing. So this is just a cross-section of a block of tissue, right? And those blue lines represent all the protons in the tissue, and they get put in this big magnet, and they all stand at attention and line up in the same direction, right? So that's what all those blue lines are. Everybody's up, they're all spinning around, but they're all oriented and aligned in the same direction. And then you bump in a pulse of radio frequency in one slice that's indicated by the red here, and it knocks them off, right? So it's like this. You take a top, and all of a sudden you bump it, and the top starts precessing around or rocking around, right? It's no longer just spinning along the axis. So as you do that, now these, and think of this as 9 different image areas or voxels in this tissue, and you're looking down at the top, and now this top is precessing around, but they're all precessing together, so there's no differentiation. You can't tell one from the other. So then you add this gradient to the magnetic field, and all of a sudden, now they're spinning at different rates in different locations. And then you add other pulses and the tissue effects, and pretty soon all of those 9 areas have a different rate of spin. And as they spin, they generate an echo or a radio frequency back. So you shout at them, and then they echo back. And the way they echo, if you listen closely, is reflective of position and characteristics of the tissue. So if you've done all this, and now you have a head with these 3 areas, and you're listening for that echo all around the head, pretty soon you can use reconstruction techniques that are very similar to what CBCT uses, and now you know where those points are, right? So we have a similar imaging technique that can be reconstructed, but instead of sending ionizing radiation through in the form of X-rays, we're sending in a pulse and listening for an echo, sending in a pulse and listening for an echo, okay? So here's the limitation, though. Conventional MRI, shown on the left, sends in that big pulse, and then they send in that gradient we talked about, and then that wiggly line down in the lower right indicates the echo, right? And you're listening for that, and you're picking it up with the antennas or the coils, and it works really well for a lot of tissues. But look at the time that takes. It's really fast, but it's 1 to 2 milliseconds. Well, for hard tissue, the echo is gone way before that. So you throw in your RF, you listen for the echo, but by the time you're listening, the echo is gone. So what the researchers at the University of Minnesota did is they developed a way to simultaneously pulse and listen at the same time, and that's what's indicated on the right. So instead of 1 to 2 milliseconds, now you're down into the microseconds. And that starts to become useful then for hard tissue. So that's how some of the acquisition parameters have also led to development of potentially making MRI more useful for our clinical needs. So what do other folks think about MRI and its potential for dental use? This is a paper that was just published electronically. I don't think it's even come out yet in print version in the Journal of the American Dental Association, but they focused on 4 emerging technologies with promise, okay? And one of those was imaging with MRI. So what they did is they looked at the capability of MRI to perform conventional diagnostic tasks, and the couple that we're interested in particular are those that I've highlighted at the bottom, the hard tissue diagnosis, where they found evidence that demonstrates that MRI enables reliable determination of cephalometric landmarks in vivo, which is good. That can replace our Ceph, right? And then they looked at hard tissue developmental anomalies, and they concluded that the study demonstrates that MRI not only provides much the same information that a panoramic radiograph usually does, but also has the advantage of a dose-free three-dimensional view. So that's like the pan, right? So if you look at those conventional tasks, they're saying, well, it has capability of the Ceph and it has capability of the pan, right? But just to duplicate what we already do doesn't necessarily move us forward, other than the fact that it does that without ionizing radiation, which in itself may be motivation enough. But they go on to say there's some new diagnostic tasks that it can do. And the one to me that really resonates is growth and development assessment. And think about for a minute if we could start doing growth studies again using MRI, so we could put children and cleft kids in these imaging, three-dimensional imaging, or create these three-dimensional imaging volumes sequentially, and now we can duplicate some of the things that were done in the historic growth studies in today's world with today's patients in 3 dimensions. And I think that's really exciting that we have that potential to move forward. So if you look at some of the other new indications, though, there's like soft tissue and muscle function. We don't think much about that, even though we know it's important because we can't really assess or image it. Soft tissue lesion. We talk about the soft tissue envelope, but we don't measure it very well or assess it very well. So these indications could actually move us forward. So not just give us what we have now, but actually advance our imaging capabilities. So we started down the road of doing some studies, and the first one that jumped in was Dr. Gamble-Slama. And she said, yeah, I'm willing to kind of blaze a trail here. And what she said is, we know that these MRI images don't have the detail. The voxel size is bigger than with CBCT. But where we really need to know the detail is at the tooth level. So if we put the digital dental models together with this MRI scan, then maybe we'd have the whole picture that we need. Okay? So she basically took a CBCT scan and an MRI scan of the same person along with their digital dental model and tried to put them together and see if she could do it as well with the MRI scan as she could with the CBCT. So her protocol was basically she segmented the teeth out, she took the digital dental model and manually got it close, and then used a surface-based automated registration algorithm to match it even better, and then did some measurement of how close did we get. And we decided that to be clinically useful, we'd really like to have it be within 0.5 millimeter, right? We don't need it within 1/100 of a millimeter, but we'd like to have it within 0.5 millimeter to make good decisions. So when we looked at the data, and she looked at everything, I put this up here because it always made me kind of laugh, that she looked at, does it matter whether we do it in the AM or the PM? And I think it was good that it turned out that the results were the same. But the important thing here is that you see the CBC data on the left, which is tighter and less error. The MRI data is a little more scattered and a little more error, but it still was clinically acceptable if you accept our 0.5 millimeter limit, which is the dotted line there. So that was good news. Then she looked at, well, can multiple people do this and get the same thing, or is it just Maddie herself that's learned to do this, and it's hard for anybody else to learn to do it? But what she found there too was that the operators were very consistent, and again, it showed the same thing, that the MRI reproducibility, there was just a little more error and a little more scatter in the data, but still was generally under that 0.5 millimeter error that we were setting as our clinical goal. Looking at specific landmarks, we see a similar picture. So we start getting a sense that maybe this is workable. Here's the whole almost 500 registration trials, but you can see a clear difference. The blue is the CBCT images, and the orange is the MRI images. So even though most of them were within that 0.5 millimeter, there's a clear difference here between the MRI and the CBCT. Right? So we still have some work to do if we're going to match it as well. So when Maddie looked at all her data, and tried to draw some conclusions out of this early pilot study, she said a couple of things. One is that these results confirmed that this process was repeatable, reproducible, and the precision was within that 0.5 millimeter clinically acceptable error that we defined at the beginning. But the second thing she said is maybe we can get increased quality by optimization of the pulse sequences. So all those variables that go into acquiring an MRI image using some of those techniques like I showed you with that SWIFT technique. She said that could potentially improve the surface-based registration for MRI. So that was a very useful first step for us to say, hey, it looks like we may have a workable way to put MRIs together with digital dental models and create a complete 3D picture of the patient with a high resolution where we need it, right? So we also looked to see what others were doing, to see what other registration techniques were being used. And this one was published where they created this sort of stent with all of these fiducials, oil-filled fiducials to help improve the registration. But even when they added up to 10 or 11 or 12 fiducials, they were only getting down to about that 0.5 millimeter error rate. So what we decided was our surface-based registration was probably as good going forward as doing this extra step of adding fiducials. So then Tracy Liang came on board and she said, I'd like to take that a step further. So Maddie had said, well, maybe if we use some different pulse sequences, we can do even better, right? So what Tracy did is she took patients that already had a CBCT and digital dental model existing from their orthodontic records, and then within 6 months, she got them to volunteer to go jump in the MRI machine and get imaged with these 3 different protocols. So what you see there, T2 space, vibe, and MP rage, are all different acquisition pulse sequences that they were trying for the MRI. So this ended up, she had 8 patients that had both of these images along with the digital dental models. And she used a similar protocol that Maddie had used to try to stitch these or match these together and create that combination data set that we were looking for. So she found much of the same thing, but some interesting things as well. If you look at that scatter graph on the left, you can see the majority of the points were below that dotted line, which is our clinically acceptable level, but all the orange ones were, right? And those are the CBCTs. So just like in Maddie's study, the CBCT seemed to do better. But then we looked at the subset of those that had artifacts at the molars because they had restorations on the molars that in the CBCT caused some scatter. And we got a flip in the results then. And actually the T2 space MRI did much better than the CBCT. So we all have this image because we get neurologists that want us to take braces off when they're doing a MRI of the brain of one of our patients, for instance. But with certain acquisition sequences, they're actually, the MRI is affected less than the CBCT in terms of trying to generate good segmentation for surface matching. So I thought this was really positive because it actually indicated a spot where the MRI outperforms the CBCT. So we're no longer just trying to get to that level. In certain cases, we're doing something better. So again, this is another couple graphs that show, again, the operators were able to do this with no difference. And again, highlighting when there were posterior artifacts, the CBCT, excuse me, actually didn't perform up to our clinical standards. So when Tracy was done, she said that generally the CBCT did better, but there was this instance that we talked about just a minute ago where the MRI actually outperformed the CBCT because of the artifacts that were present in the CBCT. She also highlighted, excuse me, I need to get back here. She also highlighted the fact that the incisors were difficult to match in some cases. And so you get this, in CBCT you get a very distinct difference between tooth and lip or air, but in an MRI, a tooth and air look much the same. So around the incisors there's often some air space between the lip and the tooth, and that can create some difficulty for matching. So we need to figure out some solution to that problem. And then she concluded again that in certain instances we can actually do better, and this T2 space acquisition protocol may be more useful in patients that have a lot of metal in their mouth. So then we started thinking, well, we've got these indications that maybe we can put these data sets together and make it useful as an orthodontic diagnostic aid, but can we really do what we're used to doing, and that is getting cephalometric information that's based, we have all this normative historical data that until we get a new growth study that provides new data, we're still reliant on our historical data, which has been validated in many ways over many years, so it's very useful. Can we do that reliably using MRI? So this is a recent scoping review by some of our colleagues in India that looked at MRI-based cephalometrics and drew some conclusion just based on their review. And what they concluded is that there's really a lack of evidence to use this as a tool for cephalometrics, but the results demonstrated by both in vivo and in vitro studies are encouraging. And then they highlight this non-radiation technique that may be beneficial, especially in our young patients where radiation exposure may be more of a concern. So what they said is we just don't have a lot of evidence, right? So we need to do better. We need to add to that database. We need to add more science and rely less on the art as we're going forward, as Salzmann would have asked us to do. So Austin is a senior dental student who decided he'd be willing to take on the task of figuring out a good way to cephalometrically analyze some of these MRI images, and we used the same image pairs that Tracy had acquired for her study. And so it's not an easy thing to do, and let me just show you a quick little video clip of, and this is an accelerated video clip of just the start of what Austin had to do to get the point. So he opens 3D Slicer and he goes through and he's getting the volume set and oriented correctly. And then as he moves forward, you will see that he's moving now that sagittal slice out so he can see the external auditory meatus and mark porion, and then he labels it. And then in a minute, you'll see him start moving that slice in so he can find orbitali. So what you can see is that it's all possible to do, but it isn't easy or fast to do, right? So then when he had all these landmarks located, he created a lateral projection that included all these landmark locations. He added some 100 millimeter fiducials so that he could then import that into dolphin. And so this is what Austin would end up with a cephalometric tracing using an MRI. So you can see we could use the same tools. There's some distortion there, but in general, you would recognize that as a cephalometric tracing. So Austin did this for several pairs, 4 different pairs, and we're still analyzing the results. But I want to just show you some of the scattergram data to give you an idea of sort of the trends that we're finding. And that is, if we're going to look at a skeletal discrepancy, maybe we would choose A and B, or maybe we'd choose widths, right? But if you look at this data, and this data shows points from both MRI and CBCT, we see that the data is more tightly clumped in the A and B, and it's more scattered in the widths. Well, that kind of makes sense, right? Because what does widths use as the reference plane? It uses the functional occlusal plane, which is defined by teeth, right? And teeth, hard tissue, are harder to visualize in the MRI. Maybe if we did this after we stitched the digital dental model on, we'd get better results. But it helps us understand that perhaps as we transform to, or potentially transform to MRI imaging, we may choose different landmarks than we have historically done in traditional cephalometrics. We see a similar thing. Let's see, I want to go back one here. I apologize here. We see a similar thing when we look at the mandibular plane angle. If we measure it to SN, the data is tighter. If we use Frankfurt, which is more difficult to localize, we're finding more scatter. So again, the selection of landmarks, if we're going to continue to use landmark-based analysis rather than some shape analysis or other iteration, we're going to have to be very thoughtful in which landmarks we choose and how we choose to use them. We see a similar thing with incisor location. We found that lower incisors were actually easier to visualize, and there was more scatter in the upper incisor. Again, not too surprising. So if we put this all together and say, well, in these 3 little pilot projects, what have we learned? What have we learned about MRI as an imaging modality for the future? We can first say that it's able to provide the information for conventional cephalometric analysis. We can identify those landmark locations and those structures that we've come to depend on in conventional cephalometrics. We can successfully merge high-resolution digital dental models with the MRI volume to add this high-resolution component where we need it, at the teeth, right? So we know we can do that. But what we also learned is that the current workflows are not well-defined and generally not ready for clinical use. So you could not do this in your office unless you were seeing like 2 patients a day, right? It would just take too long. And this is not unusual for early development of new techniques, right? First, we have to prove that you can do it, and then we have to figure out, well, how can we do it efficiently and effectively? We learned that MRI imaging for hard tissue is improving, but again, to make it useful, we're going to have to develop these pulse sequences that are basically plug and play, right? You don't want to have a highly trained MRI technologist in your office in order to acquire these scans. You want to be able to just go click their age and size or some other quick parameters like you would do for a CBCT machine or any other radiography. So we need some significant development in order to increase the ease of use. But for me, it tells me dedicated dental MRI is here. Okay, it's time for us to start using it, embracing it, and developing it, just like people did with CBCT 20 and 25 years ago. Because you go out on the exhibit floor now and there's a multitude of places where you can buy a CBCT machine that used to cost a lot of money for basically the price of a digital Ceph-Pan machine these days. So it's here. How do we go forward? Well, I've got a special opportunity because as we speak, we are looking at installation of a dedicated dental MRI unit in our school. And I think one thing I want you to understand is that those of you that listened to the keynote yesterday morning, she was an F-14 fighter pilot, and she talked about how there's like 350 controls in that cockpit, and they have to get them all right in order to have a successful mission. That's kind of like the MRI system. There are so many variables, so many controls, whereas a CBCT, even though it's relatively complex, the amount of variables and controls is more like a glider cockpit, right? You've got a few controls, but your parameters are more limited in what you can change. So it's really important for us to think about, if we're going to make this useful, how do we turn that complex military fighter cockpit into a glider cockpit? So these are two of my colleagues at the University of Minnesota that are helping to drive what we're calling OMRIC, the Orofacial MRI Center. And again, I was saying that as we speak, this is what it looks like. Okay, it's under construction. And those of you that are familiar with university construction timetables may be concerned that this won't get done in 6 weeks when our magnet's supposed to be delivered. But they promise us it's going to be ready. But let me give you, since this isn't a very good view of our vision, let me show you what we hope to create. So here's the artist rendition. This is what the imaging center will look like from the hallway. This is the entrance, and this is a resource for the whole School of Dentistry. But orthodontics is one of the core research components to this center. If you go inside, it's going to look like a small imaging center where you may go to get an MRI of your knee or some other body part. And if I show you this kind of 3D cutaway model, you can see that here is that foyer that previous rendering was from. Here's the patient waiting area. Here's a little conference room, or not. Let's see if it does it manually. There's the conference room to discuss research projects or have consultations with patients. This is the patient changing area, because we still have to get them out of their street clothes in case there's any ferrous metal, right? So that adds a little bit of complication. Here's the control room, and then finally here's where the magnet machine will sit. And it will look much like that photograph in the bottom right. So if I think back 20 years, that doesn't look too different than when John Barton brought me out to his new tome, right? It was horizontal, I was supine, lying in this machine. But we look at what's happened in the 20 years since then, and the vision is that as MRI technology continues to develop, that we can do the same thing with MRI. We already have some mock-ups of an upright MRI with a split magnet that will be more patient-friendly. So I think these things are possible if we just vision them. So here's just a series of quick images. I took a scan off that dedicated dental MRI unit, which is actually a low-powered magnet. It's 0.55 Tesla, which you would think would result in bad images, but the truth is you get less distortion in many ways. So as long as you can create an adequate signal, you actually get beautiful images. So this is a DICOM image right off one of those scanners. I just imported into in vivo and said, what would it look like if I just put it into my present 3D visualization software? And I think even though it looks very different, I think you would agree that you can sort of see the things that you want to see. And if you look at the image on the lower left, look at the detail in which you can look at the cross-section of the muscles of mastication. You can see the buccal fat pads. You can see this whole soft tissue envelope that's also influencing the long-term position of the teeth. So this is where I get so excited about not only being able to duplicate what we currently have, but add this whole new layer of soft tissue imaging, and we may develop better understanding and control over long-term stability and those sorts of things. So this is where we are with dedicated dental MRI. And I think that there's just a tremendous promise for the future. When I did this 12 years ago, it seemed like just sort of this pipe dream. And now I'm standing before you telling you that in 6 weeks we're going to have one of these installed in our building, right, that we can start playing with. So it's definitely moved forward, and I expect the pace of change to continue rapidly. But with all this new three-dimensional imaging, the other problem that comes up is this. And this is a quote I like to use when we talk about acquisition of more and more information. We get so much information that sometimes we're drowning it and we get no knowledge out of it, right? How many of you know an orthodontist that has a CBCT machine? He takes a CBCT, has his staff extract a pan and a ceph, and that's all they look at, right? Well, to me, that's not what 3D imaging is all about. But they do that because there's just too much information, and the day-to-day pressures of diagnosis and planning in a busy practice, you have to be able to stay afloat, right? So we need better tools not only to create 3D information, but for us as human beings to try to assimilate that and efficiently use that information to treat our patients better. So I want to touch a little bit on virtual reality. And the reason that this became important to me, or it was brought to my attention, is I got an email one day 4 or 5 years ago from a PhD student in the university's Visible Heart Lab. And he said, I just had a CBCT taken because I need to get my third molar removed. And I just threw it in our software that we use in the Visible Heart Lab to reconstruct hearts and valves and look at things. And I think you'd like to see it. So he brings it over to me. And it's a very simple device. He actually used his cell phone in this adapter. And all of a sudden he puts this on me, and I'm like flying through the inferior alveolar canal looking at the third molar above me. And it's just incredible, right? So it was at that moment that I said, I wonder if this is a tool that we could use to get better information faster out of all this 3D data that we're creating. So is virtual reality a tool that we could use to help us do better, not just for visualizing radiographic or MRI data, but how about just doing your digital setups for aligners? How about just looking at other 3D information that you might have? So what is virtual reality? And this is a definition that I like, because it's the use of computer technology to create simulated environments. And it places a user inside a three-dimensional experience. And here's the critical piece. Instead of viewing a screen in front of them, they're immersed in and interact with this 3D world. So instead of viewing, you're immersed. And it really is a difference that I think you can appreciate if you use one of these tools to look at 3D data. So the project I want to share with you is done by Dr. Liu, who's sitting in the second row there. And again, she hasn't defended this thesis yet, so the audience may poke some holes in it, Deb. I think this is sort of a public defense of your work here. But what she did is she wanted to figure out, well, will people even appreciate this, or what's going to be their attitude or their perspective and use of this sort of virtual reality? And for this project, we're using CBCT images, not MRI images, but it is another 3D data set that we wanted to look at. So this is one of our radiologists just playing with the setup that Deb used. And you can see he's got the goggles on, and then he has a controller in each hand. And so this is what it looks like from the outside. It looks kind of goofy, right? Somebody just kind of playing around. But if you look and see what he's seeing inside at that same time, and again, this two-dimensional image doesn't give you the appreciation of what it's really like to put these VR goggles on. But you can grab with your hands, you can point at the menus to change options. You see right there, you're selecting a slice or a cutting plane, and now they're using the right hand to control, grab that skull like it was a physical skull, and the left hand is a cutting plane that you can just move through wherever you want. And if you look carefully, you'll see there's an unerupted right canine and an impacted left canine, I think, in this one. But it really is amazing when you're immersed. Right now you're viewing this, but when you're immersed in it, it is a real difference. You're actually in the data rather than viewing the data. So I think there's a lot of potential here, and Deb tried to measure some of the aspects, how people felt about doing this. So the way these graphs work, and again, we bumped forward here. This controller is, there we go. So if things are neutral, there's a balance right and left, right? If the VR is more positive, then everything will be biased to the right side. If two-dimensional is more preferred, it'll be biased towards the left side. So when asked, does this improve your efficiency, people are saying, not really, right? There's about an even spread on both sides. And really it's not difficult to understand because this is new to them. They've just undergone a calibrated training session and then a use of it. So it isn't like they've had the opportunity to really adapt to use of this technology. And so it's not surprising that they don't feel efficient at its use, right? And there was no significant difference in this feeling by age, gender, or specialty. And just so you know, we had 3 different specialties that we looked at. The biggest group was orthodontics, but we also had some maxillofacial surgery providers and some perio providers to get a sense of whether other professions thought or acted differently than orthodontists. So you can see here there was no real difference between the specialties in that initial question. But then we said, how about which viewing method allows you to best visualize the impacted tooth's anticipated path of delivery? So how can you visualize where that tooth needs to go in order to get into the mouth where you want it? And look at the significant bias to the right now in favor of the VR. So people really felt that visualizing it this way was very helpful to be able to appreciate the 3-dimensional places in space where all these things existed. And again, I think this is a side effect of being immersed in the data rather than viewing the data. And again, this result, there was no difference by age, gender, or specialty. Similar finding if you think about how you find the position or assess the position of the impacted tooth, we have a similar bias, again in favor, but with no difference by age, gender, or specialty. There was a difference when you looked at the quantity and quality of the bone between specialties, in that, come on, controller. There we go. The oral and maxillofacial surgeons did not like VR at all to visualize bone quality and quantity. And that makes sense, right? We're viewing this with some thresholding. It's hard for them to assess how much bone is there and what its quality is. So again, an indication of where we need to add things a little more robust in order for them to appreciate that. Everybody, almost to a person, thought it was enjoyable. And that may seem kind of frivolous, but if you think about trying to get somebody to adopt something new, if they enjoy doing it, it's much easier for you to get them to repeat it time after time rather than if it's very uncomfortable. So I think that's a really positive aspect. And if you say, well, what's preventing you from using VR? You talk about cost, ease of use. And a third of the people say, I just don't think there's any benefit, right? So there's some work to do if we're going to make these tools useful and to accommodate a large portion of providers. And here's something also to keep in mind. Some people get dizzy or almost motion sick when they put these on. And about 1 in 7 of our subjects didn't feel too good. And what we don't really understand, whether this is a short-term thing where they would adapt to it, or whether this is a long-term thing, no matter how long or how much they used it, they'd continue to have problems. So this could be a potential limitation. So Deb's conclusions basically are that most providers found it enjoyable. They believe it's useful for localization and visualization of path of delivery. They didn't really see at this stage an impact on improving efficiency. We saw that the surgeons didn't like looking at bone quantity or quality. They preferred a 2D screen. This controller is driving me crazy here. And the largest barriers to using it were cost and ease of use, but there were that third that just said, I just don't see any benefit. So I think this is, again, a good initial foray so we can start building tools to make people more comfortable. But let's think for a minute on the bigger future. As we develop more 3D acquisition tools, and it may just be improved CBCT, it may be MRI, it may be some added ultrasound, there's a whole host of different technologies that may come in the next few years. How do we put those all together so that we can use them efficiently and effectively? And I think we all know that combining these data sets will be effective. There's probably going to be some element of artificial intelligence that's going to help us see things that are most important. It probably won't make decisions for us, but it'll probably point us where to look. And I think if we embrace this rather than reject it, we're going to have a much, much brighter future. So I want to circle back to what Salzmann said about adding more science and less art. And I hope that the path that we're on and the hope that the path that we're going to create with our MRI studies will help add to that science. And we always want to keep the art in what we do. That's really important. But we want to add the science where we can. And so to help Salzmann, to help Bill Profit that guided me, we really want to try to drive the science forward. So I want to give my thanks again to the foundation, and I want to emphasize their impact, because that's what really matters, right? And if you look at the $16 million they've provided, the 284 awards for fellowships, the 360 research awards, and that resulted in over 500 publications that add to our science. That's impact. So I would encourage you to give to the foundation, give to your local or your orthodontic program where you're an alum. As I mentioned at the beginning, the reason we could do a lot of this is because of our generous alums that provided funds for our imaging center. So make an impact. As we drive forward, you can make an impact. I just want to give one final shout out to the team, the residents and former residents that provided a lot of the work. Well, I should say all the work that went into these, right? And some of my colleagues, and especially want to call out Amy Tasca, who's one of our faculty members and provided the primary advisor leadership for the majority of these thesis projects that I've shared with you. So thank you to that whole team. Thank you to all you for listening. And I just want to remind you to take a moment and complete your session evaluation. So thank you very much.